Hello, my name is Yuankai Huo, a PhD student from Vanderbilt University. Today I would like to introduce our work, which is automatic characterization of pelocalcium anatomy using CT urograms to aid in management of kidney stones. So this is the disease that we are trying to treat, which is kidney stone. Kidney stone happen in 11 individuals in US, and it costs 5 billion every year, even in 2000. And 40% of the patients have recurrent stones. So how do we treat the kidney stone? Here are the traditional way of treating the kidney stone. Option 1 is we do the ESWR. The second choice is do the ureteroscope stone removal. And the third option is the PCNL. So basically, the option 1 is the best and the least harmful for the patient. And the second one is better than the third one, even both the surgery. And because in the option 2, we don't need to cut any hole or make some trauma on patient's body, and just use the endoscope to get the stone out. But in some case, the stone is too difficult to get out. So in the worst case, we need to use the option 3. And in fact, 25% of the stone patients require surgical intervention. And here is a typical ureteroscopic looks like. It has a robotic arm and has a camera. So we prefer to use this one, which is option 2, to get the stone out. But in which case we can, or in which case we cannot use the option 2, it depends on the structure of the patient's renal collection system and the location of the stone. For example, if the stone is here as a red arrow, well, it's pretty easy to get the stone out using the robotic arm. But if the stone is here, think about it. If the robotic is getting from the lower left and I want to reach the lowest point in the lower pole, it's pretty difficult. So here is the motivation of our research. So traditionally, how the surgeon decide which method to use it to view the 2D slices. Basically, they see different 2D slices from CT and do the surgery plan to choose option 2, option 3. And traditionally, we use this kind of measurement called IPA to evaluate the difficulty of the most difficult case to get the stone out. Now, our motivation is, can we get 3D visualization which help the doctor to visualize the urine collecting system or pelvis? Or can we get the better measurements for the IPA? Because the IPA is typically collected from the coronal view of a 2D slice. But when you look at the rightmost figure, the pelvis is a 3D structure which very likely not parallel to the coronal view or even with the patient's body move. So if we do the measurement on the coronal view, very likely we will do the overestimate or the underestimate. So can we do the better measurements on IPA or even get other? Okay, so here is what we can get from our method. First, we can get the 3D visualization. Second, we can get the IPA measurement in 3D manner. And we can also get the ROC curvature, and get the lower pole pathway. So how can we do that? So if we use the traditional CT, like the upper row, it's difficult to find the pelvis or the urine collection system from the CT image. But now, if we use this excretory phased CT. Well, we can see, okay, we can find the intensity contrast for the urine collecting system. So if we have some good image processing method, we probably can get the segmentation of the urine collection system from the kidney. And in this experiment, we explored this method from 8 euro unit from 6 patients, which age from 42 to 80 years old, and they are normal kidney function. So here, before I introduce our segmentation algorithm, I want to briefly recall the development of the medical image segmentation on the human abdomen. So basically, in early 2000, people started to use the probabilistic atlas method to do the segmentation. Later, people used the statistical chain model to do the abdominal organ segmentation, and later people used the graph cut, and recently people started to use the multi-atlas segmentation on the abdomen segmentation. And the majority of our method is using the multi-atlas segmentation method. So here is the processing framework. First, when we have the image, we perform the whole body multi-segmentation to get the whole kidney segmentation. Then, from the kidney, we use the Gaussian mixed model-based segmentation to get the urine collecting system and to get the 3D renderings. Finally, we can get the measurements from the 3D measurements, and we not only provide the visualization, but also provide the first, the multi-atlas segmentation to get the whole kidney. The multi-segmentation based method is typically we have multiple atlases. We do the image registration to register each atlas to the target image, and we do the atlas selection and the label fusion to get the final segmentation of the target organ. Here is the pipeline of the whole body segmentation that we use. It was worked, but this method was developed in our lab. So first, we can do the registration, do the atlas selection, statistical label fusion, and get the final segmentation. In detail, the simple method was used to perform both atlas selection and the label fusion. First, we do the registration to register each atlas to the same target image. Then we do the context learning. Basically, we want to learn some rough prior of where each organ is. Then we do the statistical selection, which basically is the selection and the voting strategy to select the best atlases based on our prior. Finally, we do the joint label fusion to get to the final segmentation, and we can even use the graph cut to refine the final segmentation results. Okay, first we do the multi-segmentation, then we can get these organs, the segmentation of these organs in human abdomen. Since we are now interested in the kidney, we can grab the kidney label from the whole body segmentation and know where the kidney is. Then the next step is to do the Gaussian mixed model-based segmentation. Here is the idea of the Gaussian mixed model. This is the expectation maximization-based segmentation method, which contains the E step, which estimates the probability of each label, and another M step, which update the parameters in the probabilistic model. And using this method, we can basically add. Now here is the example of the histogram of a kidney, and the urine collecting system typically has the largest intensity in the image, which is the rightmost peak. And if we use a GMM model, we would like to get the intensity on the rightmost peak as the segment. And here is the kidney segmentation we obtained from the whole body segmentation. Then we crop that region to get only the intensity images. And we use the Gaussian mixed model on this patch, and we can fit the multiple Gaussian distribution, and you get the rightmost peak as our pelvis segmentation. Like the green color here, we can reconstruct the 3D volume from the segmentation. Moreover, using the 3D skeleton tool developed by the Kensnitsky, we can get the skeleton of this 3D volume, which can tell us the center paths are in the 3D volume. And finally, we can rendering the skeleton, rendering the 3D volume of pelvis, and rendering the kidney together to have our 3D visualization of both kidney and urine collecting. All right, now we can also get some measurements from the 3D measurement. The IPA. Remember that the IPA used to be measured under the 2D manner, which we get the chrono view. Now, since we have the 3D model, we can get the feature point from the 3D volume, which 3 yellow points on this figure. One is the center of the getting tube, another is the center of the lowest pole, and the last one is the interface perpendicular to the tube that get into the kidney. Then we can get the arbitrary plane, not a chrono view, to cross these 3 points. And we can get these slides and measure the IPA under the 3D manner. Also, we can get the radius of curvature, which is the radius of the circle that can fit this green point, which is the path we can get into the most difficult situation of getting the kidney stone out. Also, in the same principle, if we connect those paths together, we can get the blue path on the right figure, which is the lower pole pathway, which can measure how long the path is and how difficult the surgery could be. Also, we also have some quantitative results, which we measure all these parameters for the 8 kidneys. The second column is IPA based on the traditional 2D measurements. The third column is the IPA based on the 3D measurements. And we can see there even more than 30% difference on some cases, which show in the fourth column. And the fifth column is the radius of curvature that we obtained. And we also measure the dissimilarity coefficient between the manual segmented urine collecting system with our automatically derived urine collecting system. And we derived the dice coefficient between 0.62 to 0.89. To make the conclusion, we can see it is technically feasible to use our algorithm to fully automatically. Then the discrepancy of IPA based on 2D and 3D methods suggests a role of anatomic characterization using 3D images. And the next step could be increased accuracy efficiency. We can further automate the parameter measurements, analyze the larger volume of patient, or even abstracts to evaluate the robustness. That's it. Thank you so much.